Urologic symptoms. Urologic symptoms are classified into upper urinary tract symptoms, male genital symptoms, lower urinary tract symptoms, LUTS, uremic manifestations. Urine changes, extra-urologic symptoms related to urologic disorders. Upper urinary tract symptoms. Flank pain, the commonest. Renal swelling. As a urologic symptom, it denotes huge enlargement of the kidney/SEG hydronephrosis, polycystic kidney disease and Wilms tumor. Essentially, it is a flank swelling unless the kidney is ectopic. Oliguria and anuria. Polyuria. It is the excess production of urine to more than 3 liters per 24 hours in adults. It results in painless frequent micturition. The volume of urine per void is normal or even increased. It can be caused by diabetes mellitus, diabetes insipidus, chronic renal failure, post-obstructive diuresis, compulsive water intake and diuretics. Discharge of urine, pus, or blood from a renal or ureteric fistula or sinus. It can be post-surgical, post-traumatic, or rarely spontaneous. Flank pain. The flank comprises the loin with the ipsilateral iliac fossa. Any flank pain is presumed to be urological in origin, however non-urologic causes should be considered. Urologic causes of flank pain. Renal and ureteric stones, this is the commonest cause. It may be chronic dull aching pain, especially in cases of renal stones. On the other hand, stone migration leads to hyperperistalsis of pelvic-calyceal system, renal colic, or ureteric colic. Colic is felt as severe intermittent pain of sudden onset and sudden offset. According to site of stone, pain may radiate to the suprapubic region, ipsilateral groin, scrotum, testis, labia, and urethra down to the tip of the penis. It may be associated with GIT symptoms, nausea, vomiting and abdominal distension, hematuria, dysuria, urgency, and frequency. Infection, as acute pyelonephritis, infected hydronephrosis, pyonephrosis, renal abscess and perinephric abscess. There is associated fever and local tenderness. Pain can be throbbing in nature with pus under tension. Ureteropelvic junction obstruction and ureteric stricture. Pain is usually chronic dull aching due to distension of renal capsule. It may be precipitated or accentuated by diuresis. Renal or ureteric tumors. Pain is considered a late presentation for upper urinary tract tumors. It is usually preceded by hematuria in cases of urothelial tumors. Blood clots from any source in the upper urinary tract may produce colicky pain during their passage. Other causes, e.g. cystic diseases of the kidney and vesicoureteric reflux. Differential diagnosis of renal pain, non-urologic causes of flank pain. They are not usually associated with urine changes or LUTS. Musculoskeletal causes, e.g., muscle spasm, sprain, or inflammation, rib fracture and herniated intervertebral disc. Pain is provoked by certain body positions, trunk movements, coughing, sneezing and respiration. It may radiate to the lower limbs. Gastrointestinal causes, e.g., irritable bowel syndrome, abdominal distension and change in bowel habits, cholecystis, fatty dyspepsia and jaundice, and appendicitis, rebound tenderness at the right iliac fossa and psoas spasm. Gynecological causes, e.g., torsion of an ovarian cyst and ectopic pregnancy, in females especially in the childbearing period and associated with menstrual changes. Herpes zoster, pain is severe and revealed by appearance of specific eruption along the course of the intercostal nerves. Basal pleurisy and pneumonia, related to respiration, associated with pulmonary symptoms as dyspnea and cough. Oliguria and anuria. Oliguria is urine output of less than 1 ml/kg/hr in infants, 0.5 ml/kg/hr in children and 400 ml/24 hours in adults, while anuria is cessation of urine production resulting in urine output less than 100 ml/24 hours in adults. It means acute renal failure. Causes: prerenal equals medical problem leading to decreased urine filtration due to decreased renal blood flow and subsequently filtering pressure as hypovolemia, hypotension, and shock, e.g. repeated vomiting, severe diarrhea, massive bleeding and cardiogenic and neurogenic shock. Bilateral renal vein thrombosis or bilateral renal artery occlusion. Intrarenal equals intrinsic medical renal problem with injury to the glomeruli or renal tubules by inflammation as acute glomerulonephritis. Acute tubular necrosis, either toxic, due to toxins or nephrotoxic drugs, or ischemic, due to prolonged uncorrected shock. Postrenal, obstructive anuria, equals surgical problem entailing complete and bilateral ureteral obstruction or complete obstruction of the ureter of a solitary kidney. The causes include bilateral ureteral or renal stones, calcular anuria. It is the most common. Advanced malignancy compressing or infiltrating both ureters as bladder cancer, advanced prostate cancer, uterine cancer, and retroperitoneal malignancies. Iatrogenic ureteral obstruction after gynecological and obstetric surgeries, e.g. hysterectomy. Abdominoperineal surgeries, e.g. for rectal carcinoma. Associated findings. Manifestations related to the cause. Prerenal causes: a history of massive bleeding and shock. Renal causes: a hematuria and hypertension with glomerulonephritis. Postrenal causes: a history of renal pain, urolithiasis or pelvic surgery. Uremic manifestations due to raised serum creatinine, raised blood urea, hyperkalemia, and acidosis. Ultrasonic findings: the bladder is empty. The kidneys appear obstructed in postrenal type. Lower urinary tract symptoms, LUTS. Storage LUTS, irritative. They are caused by irritative bladder pathology, e.g. bladder stone, ulcer, inflammation, diverticulum, and cancer. Increased frequency of micturition, 8 times/24 hours. Nocturia, nocturnal frequency 1 time/night. Urgency, sudden severe compelling desire to micturate that cannot be deferred. Urge incontinence, involuntary urine leakage associated with urgency. Voiding LUTS, obstructive. Hesitancy, the difficulty to start micturition. Intermittency equals interrupted stream. Weak stream or narrow stream, of narrow caliber. Straining during voiding. Terminal dribbling. Sense of incomplete evacuation of the bladder. Acute retention of urine, it is the maximal obstructive form of LUTS. Pain. Suprapubic pain, due to different bladder pathologies, e.g. acute bacterial cystitis and anterior bladder wall tumor. It can be caused by gut diseases, e.g. pelvic colitis, and gynecologic diseases, e.g. pelvic pain. Suprapubic pain, due to different bladder pathologies, e.g. acute bacterial cystitis and anterior bladder wall tumor. It can be caused by gut diseases, e.g. pelvic colitis, and gynecologic diseases, e.g. inflammatory disease and ectopic pregnancy. Urethral pain, usually is expressed as burning micturition, dysuria. It is due to inflammation, urethritis and cystitis, stones, urethral, bladder and intramural, and bladder ulcer or cancer. Low back, perineal or perianal pain, may be caused by different diseases including prostatic and urethral pathologies e.g. stones, inflammations, urethritis, prostatitis and prostatic abscess, and prostatic congestion or cancer. Urethral discharge, it is detected in the clothes and not related to the act of micturition. Its amount, color, and associated symptoms should be assessed. It includes mucus, mucopurulent, and purulent discharge, in cases of urethritis, urethral diverticulum, and around a fixed urethral catheter. Seminal discharge, due to prostatic congestion, prostatitis and sexual excitation. Blood, it is termed bleeding per urethra. The main cause is urethral trauma. Swelling. Suprapubic swelling, mostly due to chronic urine retention. Perineal or penile swelling, due to urine and/or blood extravasation after urethral trauma or penile fracture. Lower urinary tract fistulae and extravasation after urethral trauma or penile fracture. Lower urinary tract fistulae and sinuses, the cause can be congenital, inflammatory, post-traumatic, accidental or surgical, or neoplastic e.g. vesicocutaneous, suprapubic, vesicovaginal, vesicorectal or ureterovaginal. Urachal equals congenital umbilical vesicocutaneous urinary fistula. Urethrocutaneous, perineal or penile, urethrovaginal or uretherorectal. Acute urinary retention. It is the inability to pass urine in spite of severe painful desire to void with full urinary bladder. Etiology. Stone impacted in the urethra or bladder neck. Urethral trauma with complete rupture.
Prostatic diseases as benign prostatic hyperplasia, BPH, and prostatic abscess.
Neuropathic bladder e.g. after spinal cord injuries. Occasional causes e.g. reflex urinary retention due to severe painful perineal and anal conditions e.g. after surgeries for piles or anal fissure. Obstructed Foley catheter. Acute urethritis and impermeable urethral stricture. Bladder neck or prostatic cancer. Phimosis. Hysterical retention. Evaluation. A history of inability to micturate with severe desire and agonizing suprapubic pain. History suggesting the cause e.g. recent renal colic, migrating stone, old males, BPH, or recent surgery, anal, perianal and spine surgery. B. Clinical examination. Suprapubic fullness, tenderness, and dullness, without palpable suprapubic mass. A palpable bladder means acute on top of chronic urinary retention. Signs of the cause, e.g. palpable urethral stone. Digital rectal examination, DRE, may show palpable stone at the membranous urethra, prostatic tenderness in prostatitic abscess. Tender cystic bladder by bimanual examination, BPH. Abdominal U/S, it confirms bladder fullness and may detect a bladder neck stone. It detects bladder clots, in clot retention. Differential diagnosis. Clot retention. In massive hematuria, the bladder is full of urine and clots. Chronic urine retention. Although the patient is voiding, the bladder is still distended and palpable without pain or tenderness. The patient may develop acute on top of chronic retention. Anuria, no desire for micturition since the bladder is empty with the risk of uremia. Management. Emergent relief of acute urinary retention. Management. Emergent relief of acute urinary retention, first aid measure, using Naladen urethral catheter. It is contraindicated in urethral trauma, urethral stones, and urethritis. Percutaneous cystostomy can be inserted if urethral catheterization fails or is contraindicated. Insertion of Foley urethral catheter under anesthesia may be occasionally resorted to. Treatment of the cause. Urine changes. Hematuria. Pyuria, macroscopic or gross in urinary tract infection, UTI, e.g. pyelonephritis and cystitis. Crystalluria, e.g. phosphaturia and less commonly oxaluria or uricosuria. Necroturia, the passage of whitish or pinkish pieces of necrotic tissues with urine in advanced bladder cancer. Pneumaturia, the passage of gases in urine due to fistula, e.g. vesicointestinal or vesicocolic, UTI with gas-forming organisms, especially in diabetics, or after recent urologic instrumentation. Discolored urine as in, Pseudomonas infection, greenish, jaundice, brownish or olive green, and some administered foods or drugs, e.g. reddish with rifampicin. Bad unpleasant smell of urine, due to UTI by E. coli or urease producing microorganisms. Hematuria. It is the presence of more than 3 RBCs/HPF in urine sediment after centrifugation. It may be microscopic or macroscopic, gross. Etiology. Glomerular hematuria due to e.g. glomerulonephritis. Glomerular hematuria due to e.g. glomerulonephritis, e.g. post-streptococcal, IgA nephropathy, and systemic lupus erythematosus. Non-glomerular hematuria can be caused by any urologic pathology e.g. urolithiasis, infections, trauma, BPH, polycystic kidney disease and tumors. Post-urologic open or endoscopic surgery as primary, reactionary, or secondary hemorrhage. Coagulation and bleeding disorders and anticoagulant therapy. Cyclic hematuria, menstrual bleeding mixed with urine, in vesicouterine fistula and endometriosis of the bladder or ureter. Evaluation. A history of any possible cause e.g. trauma, operations, and exposure to bilharziosis. Relation of hematuria to the act of micturition. It may be initial, at the start of micturition followed by clear urine, due to a lesion at the posterior urethra or bladder neck. Terminal, at the end of micturition preceded by clear urine, due to bladder lesion e.g. bilharziosis. Total, the whole urine is red, due to bladder or upper urinary tract lesions. Color of hematuric urine, bright red urine means fresh bleeding and brownish urine means old bleeding. Presence of clots confirms true hematuria and may cause obstructive LUTS up to clot retention. The shape of clots may point to the origin of bleeding. Thread-like clots are of renal or ureteral origin, while discoid clots are mostly of urinary bladder lesions. Associated pain helps in localization of the pathology e.g. renal pain with upper urinary tract lesions and painful micturition with bladder lesions. Painless hematuria is present in e.g. BPH, transitional cell carcinoma, TCC, of urinary bladder, glomerulonephritis, and bleeding tendencies. Bleeding at other sites suggests a systemic cause. B. Clinical examination. General examination, to detect any other bleeding sites and systemic effects of blood loss, e.g. pallor, tachycardia, and hypotension. Abdominal examination for renal swellings and clot retention. DRE for e.g. BPH and bladder tumor. Inspection of avoided urine sample, see differential diagnosis. Total red discoloration of urine due to e.g. some drugs, as rifampicin, foods, as beetroots. The onset and offset are clearly related to the causative ingested material. The discolored urine is not turbid, with no clots or urologic manifestation. Bleeding per urethra, which means blood trickling from the urethra without voiding due to a urethral lesion or trauma distal to the urinary sphincters. Blood is detected at the external urethral meatus and the clothes. Contamination by menstrual bleeding, thus urine analysis is better avoided during menses. D. Investigations. Urine analysis, essential. It confirms the diagnosis by detection of RBCs. The cause of hematuria may be detected, e.g. bilharzial ova, bacteria, and crystals. It differentiates between glomerular hematuria, dysmorphic RBCs, proteinuria, and RBCs casts, and non-glomerular hematuria, eumorphic RBCs. Abdominal U/S, essential, can detect urologic lesions, e.g. renal or bladder stones or tumors. Further investigations are individualized and tailored according to the cause. When the cause of hematuria is not detected, we resort to other specific investigations, including checking the bleeding profile, urine cytology, cystoscopy, ureterorhinoscopy, and renal biopsy. Treatment entails treatment of the cause besides simple general measures, e.g. bed rest, good hydration, and hemostatic drugs. With massive hematuria, hospitalization, vital signs monitoring, and blood transfusion. For clot retention, evacuation of clots using the Layton catheter followed by continuous bladder irrigation using three-way Foley catheter. Specific measures to stop massive bleeding, e.g. hemostatic dose of radiotherapy in bladder cancer and angioembolization in renal trauma or tumors. Male genital symptoms. Erectile dysfunction, ed. Ejaculatory disorders. Subfertility. Scrotal conditions, either pain, referred, from the upper urinary tract, or due to local cause, as testicular torsion, trauma, mumps, or epididymitis. Swelling, e.g. epididymoorchitis, hydrocele, varicocele, spermatocele, hernia, or testicular tumor. Empty scrotum, e.g. testicular maldescent. Scrotal sinus, e.g. posterior TB epididymal sinus. Position of the external urethral meatus at an abnormal site, e.g. hypospadias or epispadias. Penile conditions, e.g. penile curvature, chordee ventral, dorsal, or lateral, micropenis, concealed penis, priapism, and Peyronie's disease. Uremic manifestations. Mild cases are asymptomatic, discovered incidentally, or show nonspecific symptoms as headache, lack of concentration, anorexia, and easy fatigability. The symptoms of renal failure include lack of concentration, an early symptom, headache and blurring of vision, easy fatigability, tachypnea, and palpitation, due to anemia, acidosis, and hypertension. Gastrointestinal manifestations, early, anorexia and dyspepsia. Late, dry mouth, metallic taste, nausea, vomiting, hiccup and abdominal distension. Bleeding tendency, late, e.g. epistaxis and hematmesis. Itching, Late. Extra-urologic symptoms related to urologic disorders. GIT symptoms. Acute pyelonephritis and ureteric colic may be associated with nausea, vomiting, distension and generalized abdominal pain. Huge renal swellings produce GIT pressure symptoms. Neuropathic bladder is commonly associated with chronic constipation. Constitutional symptoms. Acute bacterial infections of the kidney, prostate, epididymis, and testis can produce toxemia, bacteremia and septicemia resulting in fever, palpitation, and anorexia. Symptoms of urologic tumors: metastases. Bones, pain is localized, severe and irresponsive to analgesics. Lately bone swelling, nerve compression and pathologic fracture may occur. Brain, headache, vomiting, visual disturbances, convulsions. Chest, persistent dry cough, dyspnea, hemoptysis, and chest pain. Liver, right hypochondrial pain and jaundice. Generalized symptoms as weight loss, low-grade fever, anorexia, pallor, malignant cachexia and paraneoplastic syndrome. Focused urologic examination. Examination of a urologic patient is classic and routine. What is peculiar is loin, male external genitalia and digital rectal examinations. Loin examination. The loin is the anatomical region with the following boundaries. Superiorly, the lower border of the last rib; inferiorly, the iliac crest. Posteriorly, the later border of sacrospinalis muscle; anteriorly, the mid-axillary line. The renal, costovertebral, angle lies between the lower border of the last rib and the lateral border of sacrospinalis muscle. Loin examination is conducted mainly through inspection with sitting and lateral positions for e.g. scars, incisional hernias, swellings and sinuses. Palpation with supine position for e.g. tenderness, rigidity, and swellings. Percussion for shifting dullness or any palpable swelling. Bimanual palpation of the loin. The kidney is palpated while the patient is breathing deeply. The left hand is placed posteriorly with the index overlays the last rib on the right side while the little finger overlays the last rib on the left side. The tips of the other three fingers, the thumb is not employed, stop at the lateral border of the sacrospinalis muscle, i.e. in the renal angle. The left hand only pushes anteriorly for renal ballottement. The right hand is placed anteriorly starting below the level of the umbilicus and moved towards the costal margin. On the right side, it is parallel to the costal margin. On the left side, it is perpendicular to the costal margin. Signs characterizing a renal swelling. Site, retroperitoneal, so it is best felt at the renal angle unless the kidney is ectopic. Border, always it is rounded and never. Border, always it is rounded and never sharp. The swelling disappears below the costal margin so that one can insinuate the hand between the swelling and the costal margin unless the swelling is huge. Shape, reniform or oval. Movement and mobility. Up and down with respiration, within the paranephric space. This can be restricted or lost in pyenephrosis, infiltrating renal tumors or recurrent cases. Renal ballottement is anteroposterior movement within the paranephric space. When the left hand pushes the swelling anteriorly, the swelling is felt by the right hand and then returns back to the left hand. Ballottement is lost when a disease affects the paranephric space and fat, e.g. paranephritis, pyenephrosis, infiltrated by renal tumor, or previous renal surgery, adhesions. A huge renal swelling has no space for ballottement and it is felt by both hands at the same time, which is called renal contact. All renal swellings are dull on percussion. However, a band of colonic resonance can be detected over the swelling. Differential diagnosis of renal swelling. Parietal loin swellings. Move antero-posteriorly with respiration. Persist or become more prominent on abdominal wall muscles contraction. May overlay the costal margin. Intra-abdominal swellings. Liver, right-sided, sharp border. The hand cannot be insinuated between the swelling and the costal margin and always dull on percussion. Spleen, left-sided, sharp notched border. The hand cannot be insinuated between the swelling and the costal margin, always dull on percussion, and the direction of movement is toward the right iliac fossa. Colon, on right or left side, sausage shape, ill-defined borders and resonant on percussion. Retroperitoneal swellings, irregular shape and surface, firm to hard in consistency and not palatable, fixed to the posterior abdominal wall. Different types of renal swellings. Abdominal sonography can easily distinguish each type of these swellings. Hydronephrosis, simple renal cysts. Infected hydronephrosis, polycystic kidney diseases. Pyonephrosis, renal tumors. Male external genitalia examination. The informed and consenting patient should be examined by both hands in both standing and supine positions. Penis and urethra. The prepuce normally conceals the glands completely and the preputial opening is not narrow. It may be abnormal in e.g. phimosis, hypospadias, and epispadias. The external urethral, urinary, meatus normally appears as a dry vertical slit situated at the tip of the glands with two lips that can be separated apart to see inside. It may be abnormally, e.g. stenost, located ventrally, hypospadias, or located dorsally, epispadias. The glans is normally conical in shape and flaccid with the meatus at its tip. Abnormally, it may have e.g. inflammation, balanitis, and fistula. The penile shaft is normally flaccid straight, without curvature, with identifiable ventral corpus spongiosum, smooth surface, without induration, and no tenderness. The penile size is age-related. The lower normal length of the stretched penis is 1.9 cm in infants and 7 cm in adults. Abnormally, the penis may be e.g. small-sized, micropenis, buried below the surface of the prepubic skin, with obesity, or bowed, with chordee. Scrotum, testes, epididymis and spermatic cords. The scrotum normally has two compartments with an apparent median raphe in between, and corrugated pliable skin. Some of the scrotal lesions include e.g. scrotal sinus, bifid scrotum, Fournier gangrene and different skin diseases. The testis normally lies at the bottom of the scrotum. It has oval shape, smooth surface, firm consistency, and a characteristic testicle. The testicular size is age-related with no significant difference between the two testes. The testis is covered by tunica vaginalis, which has two layers, parietal and visceral, with minimal potential space in between. Abnormally, the testis may be e.g. agenetic, ectopic, inflamed and torsed. The epididymis is a ribbon-like structure that normally lies posterior to the testis. A laterally situated palpable sulcus separates the testis from the epididymis. The epididymis has a head, behind the upper pole of the testis, body, and tail. It may be inflamed or the site of tuberculous scrotal sinus. The spermatic cord has two parts, scrotal and inguinal. The scrotal part is available for palpation. The spermatic cord is normally soft except the cord-like vas deferens. Lesions that can be detected include e.g. varicocele, thickened or beaded vas, lipoma, and encysted hydrocele of the cord. Differential diagnosis of inguinoscrotal swellings. Examination should be directed towards identification of swelling. Origin: the scrotal neck test differentiates between pure inguinal swellings, all above the scrotal neck, pure scrotal swellings, all below the scrotal neck, and inguinoscrotal swellings, above, below, and dist ending the scrotal neck. Consistency: the bipolar fluctuation test detects cystic swellings, hydroceles, present in this mobile part. Gurgling sensation is present in hernias containing intestine, enterocele, while doughy sensation is present in hernias containing omentum, omentocele. Relation to the testis: the testis may be separable from the swelling, e.g. acquired inguinal hernia and encysted hydrocele of the cord, the seat of the swelling, testicular abscess or tumor, or concealed by the swelling with lesions involving the surrounding tunica vaginalis, e.g. vaginal, infantile and congenital hydroceles and congenital inguinal hernia. Variation in size: the swelling may be constant in size, e.g. infantile hydrocele and epididymal swellings, marked instant variation in size, e.g. hernias, or gradual variation in size over the day, e.g. congenital hydrocele or varicocele. Inguinoscrotal swellings include e.g. hydrocele: it is abnormal fluid collection between the two layers of the processus vaginalis at the inguinoscrotal region related to the testis and/or the spermatic cord. Normally, the processus vaginalis is obliterated from the internal inguinal ring to the upper scrotum, leaving a small potential space that surrounds the testis, tunica vaginalis. Hydroceles, if not complicated, usually present as chronic cystic painless swellings, and they include congenital, communicating, hydrocele: it is inguinoscrotal swelling surrounding the testis and spermatic cord with a minute communication between its sac and the peritoneal cavity. Thus it slowly evacuates and refills. It is the only type of hydrocele that shows variation in size. Infantile, non-communicating, hydrocele: it simulates the congenital type without communication with the peritoneal cavity, so there is no variation in size. Encysted hydrocele of the cord: the unobliterated part of the processus vaginalis is isolated from both the peritoneal sac and the testis. It may be scrotal, inguinal or inguinoscrotal. The testis is not involved in the swelling. Hydrocele of hernial sac: it is primarily an inguinal swelling, outside the cord, due to fluid accumulation in a closed hernial sac without any other content. Vaginal hydrocele: it is a pure scrotal swelling surrounding the testis. It may be primary, with no detectable cause, or secondary, due to e.g. epididymoorchitis, testicular tumor and ligation of lymphatics during varix ligation or inguinal hernia repair. ABCD: vaginal, congenital, infantile and encysted. Different anatomical types of hydrocele. Special clinical tests. Pinching of the parietal layer of tunica vaginalis in minimal vaginal hydrocele. Positive transillumination test due to the clear nature of the fluid. In pyocele, hematocele, or chylocele, transillumination is negative. Scrotal ultrasonography is mandatory when the testis cannot be clinically evaluated to exclude testicular malignancy or atrophy. Treatment. Conservative management, in neonates and infants waiting for spontaneous resolution over the first year. Surgery is indicated with persistence of hydrocele. Surgical excision of the sac in all types of hydrocele. In uncomplicated vaginal hydrocele, eversion of the parietal layer of the tunica vaginalis is enough. Treatment of the cause, in cases of secondary vaginal hydrocele. Inguinal hernia, it may be congenital, with patent processus vaginalis and the testis is one of the contents, or acquired, with a new peritoneal hernia sac and the testis is outside. If uncomplicated, it shows characteristic signs, namely expansal impulse on cough and reducibility. It may be complicated by irreducibility, obstruction, or strangulation, so it needs repair as soon as possible. Varicocele, it is an inguinoscrotal diffuse compressible cord swelling and its size increases with straining and decreases in supine position. It may also present with subfertility or dragging scrotal pain. It is usually left-sided and may be bilateral. Spermatocele, it is an epididymal cyst with unclear fluid containing sperms. Thus it is a pure scrotal swelling related to the upper pole of the testis, forming with the testis an H-shaped figure. It varies in size and sometimes it resembles a third testis. Testicular tumor, it is usually a painless firm testicular swelling with loss of the characteristic testicular sensation. It may be associated with rapidly formed vaginal hydrocele. Digital rectal, anorectal, examination. Digital rectal examination, DRE, begins by inspection of the perineum and ends by inspection of the examining finger after doing bimanual examination. The steps include positioning. The informed and consenting patient acquires one of the following positions. Supine position, with bilateral flexion of both hip and knee joints, is the most frequently used in urologic practice. Knee elbow position. Left lateral position. Inspection 4. Normal corrugation around the anal orifice. Loss of corrugations is present if the external anal sphincter is atonic. This raises the possibility of neuropathic bladder. Perianal and perineal abscess, sinus, or fistula. Discharge, prolapsed piles, or rectal prolapse. Signs of trauma, e.g. perineal urinary extravasation and hematoma. Scar of previous operation, e.g. urethroplasty, or skin disease, e.g. tinea cruris. Finger introduction. The hands should be gloved and the examining index finger well lubricated. The bulb of the index finger is applied to the anal verge in a light or superficial palpation manner to test for any tenderness or spasm. The pressure is increased, deep palpation, till the anal sphincter is relaxed, then the distal phalanx is flexed to be introduced into the anal canal. Proceed to introduce the middle phalanx to reach the prostate region, then the proximal phalanx to reach the bladder base. DRE is not routine in children, and if indicated the little finger is used. Findings. Anal sphincter tone. Actually there is great Findings. Anal sphincter tone. Actually there is great anatomical and functional similarity between the anal and urethral sphincters. They share the same source of nerve supply. Each sphincter has two components, one is involuntary and the other is voluntary. There is a normal degree of gripping or resistance to the examining finger by the anal sphincter tone. This anal tone may be abnormally lost or decreased in lower motor neuron lesions, direct trauma to the sphincter and in the elderly. Exaggerated in uncooperative patient, upper motor neuron lesions, painful perianal conditions and anal canal stenosis. The anal tone can be spontaneous, voluntary. It is obtained by the intentional contraction of the sphincter after asking the patient to squeeze the examining finger during DRE as if the patient is trying to hold flatus. It is resorted to when the spontaneous gripping is doubtful or seems to be absent or weak. Reflex, the bulbocavenosus reflex. It is provoked by squeezing the glands or by gentle controlled traction on an indwelling catheter if the patient is catheterized. The membranous urethra, a stone or catheter, can be felt in the midline below the prostate. Prostate. A normal prostate is not tender, with smooth flat surface and rubbery consistency, and its base is easily reached. The soft base of the bladder is felt above. The prostate has two lateral sulci, between the lateral prostatic edges and the soft rectum, and a median furrow, bilobed. DRE signs of benign prostate enlargement include convexity of surface equals of anteroposterior dimension. Exaggeration of the lateral sulci equals of anteroposterior and the transverse dimensions. Difficulty or failure to reach the prostate base equals of cephalocaudal dimension. In acute prostatitis and prostatic abscess, the prostate is extremely tender and the patient cannot tolerate DRE. In prostate cancer, signs of malignancy include nodular surface, hard consistency, obliteration of one or both lateral sulci, obliteration of the median furrow, and frozen pelvis. There is no tenderness unlike bladder cancer. Bladder base is normally soft, with smooth surface and not tender. Tender in acute bacterial cystitis, acute urine retention and bladder cancer. Indurated, firm with irregular surface in posterior wall bladder cancer. The seminal vesicles are normally impalpable. They may palpable with obstruction, bilharzial affection, or malignant involvement. The rectum, the examining finger is rotated around to detect any rectal pathology, e.g. rectal polyp or cancer. By manual examination, it is an essential step of DRE to assess the bladder between the examining finger, in the rectum, and the left hand, at the suprapubic region. It helps to detect cystic bladder mass, urine, in chronic urine retention or huge bladder diverticulum. Solid bladder mass, cancer, which is usually tender. It may be mobile or fixed. Inspection of the examining finger for blood, pus, or mucus. Urologic investigations. Intended learning outcomes. To know the urine analysis normal findings. To be able to identify various abnormalities in urine analysis report and urine analysis. It is a standard and routine investigation for every urologic patient. The standard method of urine sampling is the midstream catch. Urine should be examined physically, by naked eye. Color, normally, it varies from light to dark yellow because of concentration. Many foods, medications, metabolic products, and infections may produce abnormal color. Aspect, normally, urine is transparent. Common causes of cloudy or turbid urine include phosphaturia, pyuria, and hematuria. By dipstick testing. Specific gravity, it varies from 1.001 to 1.035. A specific gravity less than 1.008 is regarded as dilute. Conditions that decrease specific gravity include increased fluid intake, diuretics, and diabetes insipidus. A specific gravity greater than 1.020 is considered concentrated. Conditions that increase specific gravity include decreased fluid intake, dehydration, owing to fever, vomiting and diarrhea, diabetes mellitus, diabetes insipidus, and excreted contrast material. A fixed specific gravity of 1.010 is a sign of renal insufficiency, either acute or chronic. Reaction, pH. It varies from 4.5 to 8. Normally, urine is acidic with an average pH of 5.5 to 6.5. Alkaline urine predisposes to UTI. In the meanwhile, UTI with a urea-splitting organism renders urine pH greater than 7.5. Urinary pH is usually acidic in patients with uric acid and cysteine lithiasis. Urine alkalinization is an important line of therapy of such stones. Blood. Positive dipstick for blood indicates the presence of hemoglobin in urine. Leukocytes. Leukocyte esterase activity indicates the presence of pus cells, pyuria, in urine. Nitrites, normally, are not present in urine. Its presence strongly suggests bacteriuria. Protein. Although healthy adults excrete 80 to 150 mg of protein in the urine daily, the qualitative detection of proteinuria should raise the suspicion of an underlying renal, glomerular, tubulointerstitial, or vascular disease. Proteinuria can also occur following strenuous exercise. Glucose and ketones. Normally, almost all the glucose filtered by the glomeruli is reabsorbed. Detection of glucose and ketones is useful in screening for diabetes mellitus. Bilirubin. Normal urine contains traces of urobilinogen and no bilirubin. Bilirubin appears in urine in obstructive and hepatocellular jaundice. Urobilinogen increases in hemolytic conditions. Microscopically, for urine sediment after centrifugation. RBCs. The normal count in centrifuged urine is 0 to 3 RBCs/HPF. Increase in this count means hematuria. RBCs derived from the glomeruli are distorted, dysmorphic. Those derived from tubular bleeding and the lower down urinary tract have a normal shape, eumorphic. Pus cells. Dead leukocytes. Normally, a count of 10 pus cells/HPF is accepted. Bacteria. The presence of 5 bacteria/HPF reflects about 105 colony-forming units/ml. This is the standard level to diagnose UTI in a clean catch specimen. Epithelial cells are commonly observed with no clinical significance, e.g. due to contamination from anterior urethra in males or the introitus in females. Crystals. Calcium oxalate, uric acid and cysteine may be detected in acidic urine. Calcium phosphate and triple phosphate may be detected in alkaline urine. Parasites and ova, e.g. Trichomonas vaginalis and bilharzial ova. Casts. A cast is a protein coagulum formed in the renal tubule casting the shape of the tubule. The protein matrix traps tubular luminal contents. Hyaline casts contain only mucoproteins and are seen after heat exposure, and in pyelonephritis or chronic renal disease. RBC casts contain trapped erythrocytes and are diagnostic of glomerular bleeding, most often due to glomerulonephritis. Leukocyte, WBC, casts, are seen in acute pyelonephritis and acute glomerulonephritis. Special urine samples for culture and sensitivity, UTI. Cytology, bladder cancer. Postcoital voided urine, retrograde ejaculation. 24-hour urine, daily urine output of protein, calcium, oxalate, uric acid, phosphates and creatinine. Semen analysis. Indications. Male subfertility. The chance of conception decreases as the semen quality declines, however it does not reach zero. Varicocele, for assessment and follow-up. Hemospermia. Premarital assessment of fertility. Methods of obtaining a semen specimen: masturbation, recommended, or coitus interruptus. Abstinence period: 3 to 5 days from the last ejaculation. The specimen is examined macroscopically, microscopically, and biochemically. The following table shows the normal semen parameters according to WHO. Parameter: WHO 1999, WHO 2010. Abnormalities. Physical criteria. Color: white opalescent, yellowish or reddish brown. Volume: ml. 2. 1.5. Low ejaculate volume. Liquefaction: coagulates and liquefies within 20 minutes. No coagulation. Prolonged liquefaction. pH: 7.35-7.50. 7.2. Acidic. Sperm criteria. Sperm concentration, million/ml. 20. 15. Oligospermia, low sperm concentration. Azospermia, no detectable sperm. Total sperm count, million. 40. 39. Progressive motility, %. 50. 32. Asthenospermia, decreased % of progressively motile sperms. Vitality, %. 75. 58. Necrospermia, increased % of dead sperms. Normal morphology, %. 30. 4. Teratospermia, increased % of abnormal forms. Cells. Leukocytes. Million/ml. 1. Leukocytospermia, pyospermia. RBCs. 0. Hemospermia. Abnormal semen analysis should be repeated twice or thrice over a period of several weeks to confirm abnormalities present in the first specimen. Hemospermia is a symptom, however the presence of even a single RBC in semen is considered hemospermia. It can be idiopathic, or caused by prostatic congestion, inflammations, trauma, or tumors of organs involved in the process of ejaculation, e.g. TB of the prostate or seminal vesicles and prostate cancer. Acidic semen and absence of fructose are encountered in bilateral ejaculatory duct obstruction. Urologic imaging. A. Ultrasonography, U/S. It is cheap, rapid, real-time, safe, radiation-free, easily and widely available. It provides a good tool for patients' follow-up and guidance of needle biopsies. However, it is operator-dependent, requiring experience and direct contact to the area under examination. Abdominal ultrasonography. It is actually a bedside test and can be considered a part of the routine abdominal clinical examination. It can assess kidneys, site, size, echogenicity, stones, obstruction, cysts, tumors, and paranephric collections. Ureters, they can be traced by ultrasound if they are dilated. Bladder, it should be full at examination to detect stones, masses, and intramural ureteric stone. Lastly, it evaluates post-void residual, PVR, urine. Other abdominal organs and intra-abdominal collections. Normal sonographic appearance of the kidney, left, and urinary bladder, right. Scrotal ultrasonography evaluates scrotal masses, cystic, e.g. hydrocele, or solid, benign, or malignant. Color duplex ultrasonography is used in cases of varicocele, degree of venous dilation and presence of reflux, and testicular torsion. Penile color duplex ultrasonography in cases of erectile dysfunction. Transrectal ultrasonography, TRUS, evaluates the prostate, volume, suspicious foci, stones, or abscess. It can guide prostatic biopsy. Seminal vesicles and ejaculatory ducts for e.g. obstruction. B-plane X-ray of the urinary tract or KUB, kidney, ureter, bladder, film. It requires prior bowel preparation and carries the risk of ionizing radiation, so it must be avoided during pregnancy. Colonic gases may obscure findings and details. KUB film can show bones. Normally bones are used as landmarks for the urinary tract. The renal pelvis lies opposite the second lumbar transverse process. The middle ureter lies opposite the sacroiliac joint. The posterior urethra lies opposite the symphysis pubis. Urologically related bone abnormalities include e.g. spine deformities, as scoliosis and sacral agenesis, fractures, as pelvis or spine fracture, and metastases, osteolytic or osteosclerotic. Radio-opaque shadows. Radio-opaque stones. Opacities that may be confused with stones include calcified lymph nodes and pelvic phlebolyths, round, lucent center, usually below the ischial spines. Abnormal calcifications e.g. TB renal calcification and linear bladder/ureteral bilharzial calcification. Foreign bodies as urologic stents and metal clips. Renal soft tissue shadow normally appears just lateral to the psoas shadow. The psoas shadow can be obscured by retroperitoneal masses, e.g. hugely enlarged kidney, or collections, pus or blood. See abdominal computed tomography, CT. It shows both the urinary tract and other abdominal organs. It uses ionizing radiation as KUB and IVU, however with higher doses. Thus, these three modalities are contraindicated during pregnancy. Non-contrast CT, it can detect both radiolucent and radio-opaque stones and determine their densities. It shows the site and shape of the kidneys irrespective to their function, e.g. ectopic and horseshoe kidneys. Contrast CT. Contrast media are water-soluble triiodinated benzoic acid compounds, administered intravenously and excreted by the kidneys. Their adverse reactions are hypersensitivity and nephrotoxicity. So, they are contraindicated in cases of contrast hypersensitivity, renal impairment, and diabetics receiving metformin. Preparation. It needs prior good hydration and normal serum creatinine. Indications include genitourinary tumors, diagnosis, staging, and follow-up. Urinary tract trauma, mainly renal and ureteric trauma. Obstruction, ureteropelvic junction obstruction and ureteric stricture. D. Intravenous urography, IVU. It has been largely replaced by CT since it cannot assess renal cortical lesions, non-functioning renal unit, acutely obstructed kidney during renal colic or other organs. It is still valid in assessment of upper urinary tract obstruction, ureteropelvic junction obstruction and ureteric stricture, and if CT is not available. Other urologic contrast studies. Retrograde urethropelvic to detect urethral stricture or rupture. Retrograde cystography to detect bladder rupture. Voiding cystourethropelvic to detect vesicoureteral reflux, VUR, and posterior urethral valve. Retrograde ureterorenography, intraoperatively, to detect ureteric injury, localize ureteric stricture and at the start of percutaneous nephrolithotomy. Antegrade nephrostography, through a percutaneous nephrostomy tube, to define the site of obstruction. Magnetic resonance imaging, MRI, includes. Magnetic resonance urography replaces CT in cases with pregnancy and studies with 4 contrast in renal impairment and contrast hypersensitivity. Multiparametric MRI can be used for assessment of genitourinary tumors, especially prostate cancer. The patient should put off any metallic object. Moreover, the procedure is contraindicated with claustrophobia and any metallic prosthetic implant. Renal scintigraphy, radioisotope scan, determines the differential renal function and confirms upper urinary tract obstruction. It is permissible with renal impairment, however it is firmly contraindicated during pregnancy.